was 57, and 80% of the cancers were squamous cell carcinoma, and more than one third of the cancers, out of which were in the middle one third of the esophagus. On Female sex and history of substance abuse were associated with the higher odds of squamous cell carcinoma and presence of comorbidities, and obviously the lower end of the lower end junction primaries were associated with the higher end of adenocarcinoma. Surgical anatomy. Esophagus is a fibromuscular tube which runs from lower end of the cryptopharynx up till the gastroesophageal junction. It's 25 centimeter long and the distance is measured from incisor teeth. It is lined by stratified squamous epithelium and it transits into columnar at Z line. Traditionally, for obvious reasons, squamous cell is more common in the upper end, the middle, and lower end. Adenocarcinoma is more common. Here is the picture. Yeah, so surgically, conventionally, esophagus has been divided into three parts, that is upper, middle, and lower thoracic esophagus. From the beginning up to the lower border of the azygous vein is the upper esophagus. The middle 10 centimeters, that is between the lower border of the azygous to lower border of the inferior pulmonary vein, is the middle esophagus. And the lower thoracic esophagus starts from inferior pulmonary vein up to the termination into the stomach, that is gastroesophageal junction. Here is a Stewart classification for usually used by surgeons for the tumors of the adenocarcinoma of the gastroesophageal junction. Basically, this divides the tumor in the gastroesophageal junction region into three types, type 1, 2, and 3. Where they see the epicenter of the tumor. Epicenter is nothing but they move the upper and the lower border of the tumor and they take a midpoint. If that midpoint or the epicenter of the tumor is proximal to the gastroesophageal junction from 1 centimeter to 5 centimeters, that is type 1. Type 2 is 1 centimeter proximal up to 2 centimeter distal to the gastroesophageal junction, that is type 2. Type 1 and 2 are generally for surgical management, are managed as cancers of as like that of esophageal cancer. And type 3 is something which runs from 2 centimeter after the gastroesophageal junction up to the 5 centimeters. And this type 3 is the worst prognosis and they are managed like carcinoma of the stomach. Here is a unique characteristic of the gastroesophageal junction cancer that the lymphatic drainage is very peculiar. So identifying the exact tumor location of that is of great importance and strongly influences the pattern of lymph node involvement and metastasis. Here, as you can see, there are upper, mid, and lower esophagus are draining into a particular group of lymph node. So it is very important to know the exact location, and accordingly we can look for any metastasis in a particular lymph node. Now coming to the workup. Patients, when newly diagnosed, should undergo all of the following in workup. I have taken this from NCCN guideline. Complete history, physical examination, CBC with comprehensive chemistry, upper GI endoscopy with biopsy of the primary tumor. Histopathological evaluation is required for the correct diagnosis. If it's a squamous cell or adenocarcinoma, we will see in further slides that the outcome depends on histopathology as well, so it is very important to have a biopsy evidence of a tumor and the subtype. CT scan of the chest and abdomen, and if required, pelvic CT as well. Endoscopic resection is recommended for accurate staging of early stages like T1A and 1B. And endoscopic resection may also be therapeutic for early stages of the disease. FDG PET-CT from skull base to mid-thigh is recommended if the metastatic disease is not evident. And if we do FDG PET-CT, usually it results in 10 to 20% cases. There will be upstaging of the disease. There might be some operant metastasis, including retroperitoneum, which we can find on PET-CT. This is the endoscopic ultrasound image of esophageal mucosa. The center part is the probe and the scope depth. And the first bright white rim you can see is the interface. Then first hypoechoic rim, which is labeled as MM, which is mucosa. The second hyperechoic rim, there are alternate hypo and hyperechoic rims. Second is the submucosa. Third is the muscularis propria. Now, this is the very important structure here, which will determine the stage of the disease. And the outermost layer is the adventitia. Now, here we can see that endoscopic ultrasound image of a tumor where the tumor is not invading into the muscularis propria, but it is invading into the submucosa. So here the stage of the cancer is like T1B. Here we can see that the endoscopic ultrasound is showing that the tumor is invading almost invading into the aorta. So here the stage of this cancer will be T4. Further workup-wise, biopsy of the metastatic disease should be performed as clinically indicated and may be used for biomarker testing. Assessment of severe tumor type should be included in all type of initial workup in all patients with gastroesophageal junction adenocarcinoma. If the tumor is located at or above the carina, there should be, and there is no evidence of metastasis, then bronchoscopy should be done and biopsy should be done of any abnormalities in cytology of the washing should be done. Nutritional assessment and counseling as well as smoking cessation and should be recommended for all the patients. MSI and PDL1 testing is recommended from at the time of the diagnosis if metastatic disease is documented or suspected, and HER2 testing is recommended if if metastatic adenocarcinoma is documented or suspected. The guideline also recommends the screening of family history of esophageal or gastroesophageal junction cancers, and referral to a cancer genetics professional is recommended if there is a family history or a known high-risk syndrome associated with esophageal cancer. Initial workup will enables patients to be classified into two clinical groups, which is locoregional cancer as well as metastatic. We will see in the further presentations about the management of all these stages. As far as staging is concerned, the 8th edition of the American Joint Committee on Cancer Staging of epithelial cancers of esophagus and esophagogastric junction presents a separate classification for clinical, pathological, and post-neoadjuvant stage groups. Histopathological subtypes markedly affect the survival of clinically and pathologically staged patients and require separate grouping of each cell type. But the post-neoadjuvant chemotherapy grouping are identical in both cell types. Clinical categories typically obtained by imaging with minimal histological information are limited by resolution of each method. However, prognostication using a clinical stage group remains very inaccurate compared to that of a pathological TNV staging. Pathological staging is losing its relevance when it comes to the advanced cancers because of neoadjuvant therapy has replaced esophagotomy alone as a treatment of choice. However, it is very much relevant and important for early stages of cancer, where a staging and survival as a staging and survival reference point. Prognostication using a pathological stage group is the most refined of all the classifications. And post-neoadjuvant chemotherapy (PNM) is introduced by AJCC because the absence of any equivalent pathological TNM categories for these categories, which particularly arise after a post-neoadjuvant chemotherapy, which are P0, N023, M0, and PIS, N023, M0, and markedly different survival profiles in these patients. Thus, prognostication is very specific for the patients who are undergoing neoadjuvant chemo. But the role of this post-neoadjuvant chemotherapy PNM classification in additional treatment decision making is not currently clear. Now, this is the as we already know, it's TNM staging. Here, T0 to TIS, which is a high-grade dysplasia. T1 is a tumor invading. T1A is tumor invading into the lamina propria and muscularis mucosa. 1B is into the submucosa. T2 is tumor invades the muscularis propria. T3 is in adventitia, and T4 invades the adjacent structures. In which T1 4A is into the pleura, pericardium, diaphragm, peritoneum, and azygous vein. And the T4B is into the aorta, vertebral body, and trachea. This is again a simplified picture of carcinoma in situ, then stage 1, 2, which is extending into the muscularis propria, 3 is into the serosa, and 4, which is into the surrounding structures. Lymph nodal status wise, regional lymph nodes, N0 is no metastasis, N1 is metastasis in 1 to 2 regional nodes, 3 to 6 is N2, and more than 7 or more is N3. And there is also, like we haven't learned about the regional lymph node, that way the same, we have a similar lymph node stations for esophageal cancers as well. Adenocarcinoma was further, adeno and squamous cell carcinoma was also divided according to the grade of the tumor, in which G1 to G3 well differentiated towards poorly differentiated, same way in squamous cell carcinoma as well. And squamous cell carcinoma was also classified according to the location of the tumor, that is upper surface. We have already seen upper, middle, and lower, depending upon the structures. Histopathological subtypes markedly affect the survival and clinical TNM staging in patients. And survival of early intermediate stage patient is worse for those with squamous cell carcinoma as compared to that of adenocarcinoma, which necessitates the separate staging and grouping of the cell types. So this new AJCC classification classifies staging of adenocarcinoma and squamous cell carcinoma is separate. However, the histological grading also affects the T1 to T2 adenocarcinoma and T2N0M0 squamous cell carcinoma. But because of the accuracy of reporting the G status on biopsy, it was eliminated from this classification.
Please summarize the list 3 points. Squamous cell carcinoma remains the most common histological type in esophageal cancer. If we look at the thoracic BMD, the number of tumors that is yearly accounted the number of tumors that present in a year. Lung cancer is the most common, accounting for around 2,500 patients that we see in the OPD per year. Next, following that is esophageal cancer, roughly accounts for around 800 to 1,000 patients. More than 50%, so 50 to 60% of these patients are metastatic, and 60 to 70% of them are esophageal cancer. So if you look at the 8,000 patient analysis that we did, over the entire 20 years period in India, esophageal cancer squamous cell remained the most common histological type. What is important is when we see down the line, majority of the studies focus on adeno rather than squamous. The squamous histological subtype is only 25%. But why are our studies more important? Is that the response rates and survival were more in the squamous cell histology as compared to the adenocarcinoma. We'll come to that. Regarding what all investigations are required in the thoracic JC when we discuss all of these patients is primarily they classify as supracarinal disease and infracarinal disease. The importance of supracarinal disease is that we need to do an FOD and rule out any form of tracheal invasion, indenting, fistula, because the treatment management will completely change based on that. So if there's any form of suspicion of mucosal irregularity, they may give neoadjuvant chemotherapy and see whether there's any fistula post neoadjuvant chemotherapy. Secondly, if there is already a fistula or a fistulous communication, there is no role of surgery in that. You will not give radiation because the fistulous tract will increase, and it will be neoadjuvant chemotherapy or then alator therapy subsequently. Okay. The regarding the staging. So T2 onwards, everything is a systemic disease. Okay, so just like in bladder, any muscle involvement is systemic disease. T2 involvement is systemic disease. In Japan and other Asian countries, the submucosa is further divided into SM1, 2, and 3. From SM2 onwards, the risk of systemic disease increases. So for all practical purposes, it is T2 onwards. For some countries which have very as a routine surveillance, as a routine screening, if they do upper GI endoscopy for esophageal cancer, they classify us from SM2 onwards as a high risk for esophageal disease. So we'll go ahead with the clinical presentation and molecular profiling, and I think to further put a light on what is to the frequency and incidence of HER2 mutation tumors and other molecular data.
So, Mani, today I'll be talking about the risk factors clinical presentation in molecular profile of esophageal carcinoma. So, I'll be talking about the risk factors clinical presentation and molecular profiling. So, this we had already seen in the previous presentation that esophageal carcinoma is more common in Southeast Asia. In India, it is more common in Northeast India and in Kashmir. So again, this is a review of the PMH data. During this time, we just move forward. Like it was mentioned previously, both squamous and adenocarcinoma have different genetic profile, different clinical profile, and in some studies they had different survival outcomes also. For them, for both these histologies, the risk factors are also different. What you'll notice that squamous cell carcinoma, tobacco and alcohol are very important risk factors. And one interesting risk factor that was seen in squamous cell carcinoma is ARDH2 deficiency. Now, this is an enzyme which is used for is used by the body to metabolize alcohol, and is deficient in Southeast Asian population and also in the population in Northeast India. So that could be one of the reasons why squamous cell carcinoma is more common there. Whereas if you look at the risk factor profile in adenocarcinoma, it is GERD, Barrett's esophagus, reflux symptoms, and obesity. Now, these are things that are more commonly seen in high-income countries and more towards the West. So, since the major histological subtype that we'll be dealing with in our clinic is squamous cell carcinoma, I thought I'll go ahead and look at the data of that risk factors. This image is from a review published by the CCE at ACTREC. So this it shows the level of evidence for the different risk factors in squamous cell carcinoma. As you can see at the top, there's tobacco, alcohol, and some interesting things like hot beverages, use of areca nut, lower socioeconomic status, poor oral health, and genetic susceptibility. The others I have very limited data, so I won't touch on them much. Now, I've had a look at here for the strongly associated risk factors, we have a lot of data from India which shows that tobacco has a 2 to 7-fold increase in squamous cell carcinoma, and alcohol also has been increased, has shown an odds ratio of about 2.21 in the development of squamous cell carcinoma. Similar data is also available for areca nut chewing, for oral health, low socioeconomic status, diet deficient of fruits and vegetables, and consumption of hot beverages. What you'll notice is that a lot of the Indian data has come out of Kashmir and Northeast India because of the high prevalence in these areas. So to understand the clinical presentation, we first have to understand a little bit about the natural history of squamous cell carcinoma. Both squamous and adeno usually present as a locally advanced or a metastatic disease. This is primarily because of anatomical reasons. The esophagus is in a hidden anatomy, and usually the symptoms won't appear until a locally advanced stage. The esophagus does not have a serosa, so the local invasion of tumors is more common, and it also has a rich submucosal lymphatic network which contributes to the spread of the disease. Even apparently localized disease, that is like sir mentioned, T2 disease will usually have occult micrometastasis. In fact, one study found that during transthoracic esophagectomy, when they did an analysis of the rib tissue that was removed, almost 80 to 90% of patients with T2 and above disease had micromets to the ribs. So there's also a difference in the clinical behavior of squamous cell carcinoma and adenocarcinoma. Squamous cell carcinoma is more prone to burrowing, as you can say. It is localized infiltration, tends to go into the local structures. So squamous cell carcinoma can tend to present with fistulas, with exsanguination because of infiltration into the aorta. I'll move into that later. Whereas adenocarcinoma tends to present with distant metastasis. So the symptoms will be different depending upon where in the esophagus the tumor is. In the thoracic esophagus, it's usually progressive dyspnea, odynophagia, retrosternal pain, bone disease if there is lip involvement, hoarseness of voice because of involvement of the recurrent laryngeal nerve, aspiration pneumonia secondary to esophageal fistula, and aortic invasion causing exsanguination. Whereas the thoracic esophagus will present as throat pain, lump in the neck, and weight loss or ear pain. Uh, Based Indian data for this retrospective analysis on the Adyar Cancer Institute found that 89% of the patients presented with locally advanced disease and predominantly with the symptoms that we had seen in the previous slide. Data from Mumbai showed that the most common presenting symptom was dysphagia, 97%, of which 68% of patients presented with both dysphagia to both solids and liquids, and the rest presented with dysphagia to solids alone. The majority of patients had a short duration of symptoms of less than 3 months, and other symptoms noted were anorexia, weight loss, GI bleed. Interestingly, GI bleed was low at only 3.8%, and as expected, tracheoesophageal fistula was only 1%. So the cervical lymphadenopathy was also limited at only 4%. Now coming to the molecular profile of esophageal carcinoma. So as you've seen, the clinical profile of esophageal adenoid squamous carcinoma is different. Similarly, their genetic profile is also wildly different. This where the squamous cell carcinomas tend to have lesions that affect the cyclin and cyclin-dependent kinase pathways, whereas the adenocarcinomas tend to have amplifications in tyrosine kinase pathways. This becomes important because these are targetable. So if you look at the mutation profiles in both adeno and squamous carcinoma, I just want you to look at this part with the yellow. So that yellow shows the frequency of mutations in EGFR and HER2 mutations. So it's around 10 to 20% in adenocarcinoma esophagus. And this becomes important because again, these we have targeted agents to this. Whereas if you look at squamous cell carcinoma, it's primarily this in the FGF family of genes and TP53 mutations. Another part that was also increased in squamous cell carcinoma is the WNT pathway. So data has now come which shows the accumulation of mutations. We now have a clear idea of the natural history of adenocarcinoma. So first you can see this. The first few mutations that come are this is the cyclin-dependent kinase inhibitor 2A, followed by further mutations of TP53 and SMAD4. SMAD4 is a transcription factor which regulates the cell cycle. Unfortunately, for squamous cell carcinoma, we don't have such a natural history like the progression of the disease. Similarly, other than mutations, there are also epigenetic changes, and the genes. This is a list of genes that are hypermethylated in both squamous and adenocarcinoma. So hypermethylation reduces the expression of genes, and as you can see, that the genes are different in both. So based on both the genetic and epigenetic profile, an effort was made by the Cancer Genome Atlas Network to classify esophageal cancers based on their transcriptome profile. So they have classified both esophageal squamous cell carcinoma and adenocarcinoma separately. Esophageal squamous cell carcinoma, which is seen in the brown, as you can see, is most commonly seen in the upper and middle thorax, upper and middle esophagus. They had classified this into ESCC 1, 2, and 3 based on the upregulation of proteins, and they found that especially the ESCC1 was resistant to chemotherapy. This was a mutation that was more commonly seen in the Vietnamese population. We don't have any Indian data based on this. The remaining 4 types, as you can see, CIN, that is chromosomal instability, EBV, which is Epstein-Barr virus related, MSI, which is microsatellite instability, and GS is genomically stable. So these are seen more towards the lower end of the esophagus, and these are they share a lot of genetic profile with the stomach carcinomas. So each of these is shown to have a different distinct behavior and a different response to therapy. So the most a number of targeted agents have been studied in esophageal carcinoma, particularly in the metastatic setting. So these are mainly EGFR, HER2, VEGF inhibitors, and they've also included PDL1 inhibitors in this image. So this is something I've lifted straight out of the data. You can see these are all the studies done for targeted agents in esophageal carcinoma in a metastatic setting. But it is actually what I want to give to look at is the response rates, which become important when we're looking in a locally advanced setting. So response rates have generally not been good, but there are a few agents that have a reasonably higher response rate. Like trastuzumab deruxtecan, a response rate of 51 versus 14, and ramucirumab with a slightly higher. Okay. Uh,
One very important point that we said regarding the clinical profile, what is different between squamous and adenoid. We said something about burrowing and adenocarcinoma more likely to spread. So, did you notice anything in the molecular profile which favors such a clinical behavior? If you see particularly VEGF and ERBB2, two particular molecular markers or expressions which neoangiogenesis and distal metastasis. Whereas cyclin D1, iron, so all of these are for local progression and cell cycle control, which is one investigation modality that we do additionally in adenocarcinomas in the G junction before starting any form of neoadjuvant therapy. It is based on what we were discussing. So staging laparoscopy is something that is done for adenos, not preferred for squamous, because the behavior is such that adenocarcinomas exfoliate and spread into the peritoneal cavity, not so very common. So it's not an absolute no-no, but not so very common in squamous cell carcinoma. So all patients were planned for neoadjuvant perioperative therapy for G junction tumors, Sievert 1 and 2, always undergo initially staging laparoscopy.
Why would you do a staging laparoscopy? Why can't you pick it up on imaging?
Many times the peritoneal metastases are not picked up on the scan, and when they go for surgery, it's found a widespread disease. So we want to avoid unnecessary.
Basically, abdominal nodules less than 1 centimeter, which are often the way the spreads are not picked up on peritoneal. That is one.
The second thing is about the most successful targeted therapy for esophageal cancer as of now is HER2. So HER2 has come into the category 1 recommendation in NCCN. So right now it's metastatic, it's chemo with or without IO with or without HER2 directed therapy as a first line. Okay, so if we consider esophagus alone, it's around 2 to 5%. When we combine that Sievert 2 and 3 along with that esophagus, the numbers increase to 15 to 20% like what Rohan was saying. So now let's go on to the next the important trials which actually shape the management of esophageal cancer. And we'll begin first with surgery. So surgery was one of the most important modalities which initially showed a significant survival benefit over RT alone. That was the first treatment modality that they gave. And we called Dr. Anoki for that.
And the surgical staging was done, the early localized people do not without any localized early and localized disease, T1 or T2, which has been confirmed by the US, and there is no longer involvement. The surgery was the upfront thing which showed the benefit. If it is a R0 resection, there is no need of any adjuvant treatment, which was previously stated. So when the tumor is T1A, so it's just below the submucosa. So at that time, we don't need to go for the total esophageal study. We just can get other means. So for mucosal tumor, only the endoscopic mucosal resection or plus or minus ablation can be done. So this type of patient is who have this type of presentation. So normally Barrett's esophagus, which is called as a pre-malignant disease for the esophageal cancer, with the high grade dysplasia, we can get away with endoscopic mucosal resection. And the tumors which are T1A in disease can be get away with this endoscopic mucosal resection. So these patients, they have a lymph node metastasis risk. So before labeling that N0 and we opt for EMR for this patient, we have to get them the FNSC of a lymph node to rule out that if there is any lymph node metastasis is there or no. Because in category T1B tumor, at presentation, 20% have the lymph node metastasis. So in that patient, we can opt for the radical esophagotomy, and in that time, that mucosal resection cannot be helpful. So criteria for therapeutic endomucosal resection is mucosal lesion only T1N. There should be no ulceration, no LVI. The tumor size should be less than 2 centimeters, and it should not be poorly differentiated. So 5-year OS with this T1A lesion is almost 98%. So this is for the T1A disease. So now the main thing is which cancers, which esophageal cancer should not be resectable. Like metastatic disease, as we all know, T4 disease, which is invading the surrounding structure, cervical esophageal tumor. So cervical esophageal tumor, we cannot remove the portion of oropharynx, larynx, thyroid, and that important structure. So in that subset, we go for CTRT. And with the patient, if the patient's PS is poor or too many comorbidities, age is advanced, so in that patients, we avoid the resection. So esophagotomy indications are upfront esophagotomy be done in the clinical T1 N0 M0 or possibly clinical T2 M0 M0. In cross trial, the only resectable patients were who had a T1 disease only. They didn't even involve T2 disease. So treatment for T1 N0 M0 stage 1 diseases, surgical resection is the standard of care. So total esophagectomy is required for the tumor of mid-third and lower esophagus, and removal of entire thoracic esophagus with cervical anastomosis. Why we remove all the esophagus? Because they have a tendency for steep lesion, because they have very rich lymphatics. So submucosal spread is known in this patient. So we have some options for this patient. So transhiatal or transthoracic approach. So transhiatal approach and transthoracic, both approach are valid. There are multiple randomized trials to whom we should offer this. So transhiatal approach, there will be a rectotomy and cervical approach with the peritumoral or 2-feet lymph node dissection. And there will be en bloc resection feasible for the distal esophageal tumor, and there would be a cervical anastomosis. In transthoracic, the normal surgery they do is Ivan Lewis surgery. That had a right thoracotomy and laparotomy, and there would be peritumoral or 2-feet lymph node dissection, and there would be an en bloc dissection feasible for middle and distal thoracic tumor. And mecoinment, there is a 3 holes. So there will be right thoracotomy, laparotomy, as well as cervical approach. And there will be peritoneal 2-feet or 3-feet lymph node dissection, and there will be a cervical anastomosis. So transhiatal esophagotomy, so it can dissect the cervical, thoracic, and GEG cancer. Upper midline laparotomy incision and left neck incision is referred in this. So only disadvantage of this transhiatal esophagotomy is that we cannot see the full thoracic lymphadenectomy because we are going from transhiatal route, and we cannot entirely see the mid-thoracic dissection. So there will be the most common complication of this type of esophagotomy is the anastomotic leakage, that is 9%, and post-op epileptics and the pneumonia chance is 2%. So when there is a high chance of pulmonary comorbidity, we prefer this approach because the transthoracic approach has more pulmonary complication. So transthoracic esophagotomy, Ivan Lewis. So it is preferred for lower third esophageal cancer, not ideal for mid third tumor because of the limited proximal margin. there will be laparotomy, right thoracotomy, and there will be intrathoracic esophageal-gastric anastomosis. So because of this, there will be more chance of leak, bile reflux and leak. So the advantage of this procedure is a surgeon can see the entire thoracic esophagus and can do complete thoracic lymph node dissection in this patient. Proximal esophagus, it cannot be visualized properly. There will be an anastomotic site will be in the intrathoracic location with esophageal-gastric anastomosis. Main complication, as I mentioned, that it will be severe bile reflux chances is there, and if leak occurs intrathoracic anastomotic site, there will be high rate of mortality as well as morbidity. So most common complication in this patient is according to pulmonary respiratory distress, atelectasis. So if there is a high chance of if the patient has pulmonary comorbidities, we should prefer THE approach rather than TPE approach. So optimal surgery, which surgery to choose? So there was a transhiatal as well as transthoracic. So there was a Dutch trial, randomized control trial, which included a 220 patient, which contained the adenocarcinoma of distal esophagus, G junction, and gastric cardia. They randomized it. So R0 resection was the similar in there. There was no difference in resection rate. There was no difference in the overall peri of morbidity or mortality rate. There was no difference in median BFI, OS, or local regional rate, but the greater morbidity with transthoracic esophagotomy was there was a significantly higher pulmonary complication. There were more ventilatory time, ICU stay, and hospital stay. But the 5-year BFS and OS, which came after that, it was suggestive, it was favoring more of the TTE approach than the THE approach because the lymph node retrieval was more with the transthoracic esophagotomy. So this was the this paper where they showed the disease-free survival among the patients who randomized with the TP or THE approach. At 2 years, there was no difference in ODFS or OS, which was statistically significant. So there is a chance of mortality of around 5% with this surgery. The hospital and surgeon volume is a big impact on peri of mortality. The major cause of problems are cardiac and respiratory failure, and usually full recovery of QI by 12 to 24 months. So there was one new approach when there is an open esophagotomy, whether we can go for minimal invasive esophagotomy or where we go as a hybrid minimal invasive esophagotomy. In hybrid, it says that where one approach will be like laparotomy will be there, so there will be thoracoscopy. So one will be invasive, one will be minimal, one will be open, and one will be minimal invasive. So in this MIRO trial, they have given the main objective was that 30 days, grade 2 to grade 4 post-operative morbidity in patient substance. So they investigated whether the hybrid minimal invasive esophagotomy reduced the morbidity compared with the open esophagotomy in patients with the resectable esophageal cancer. The MIRO trial. So they have included the patient who had the middle or lower third of the esophagus who is eligible for the IVO procedure after standard preoperative workup. So in hybrid surgery, they did the two-field abdominal thoracic operation, and there was the laparoscopic gastric mobilization and open right thoracotomy. So where we can see that where a primary endpoint was the major complication at 30 days. So in hybrid minimal invasive esophagotomy, only 16%, 36% had that complication, but open esophagotomy almost 64%, 64% patient had a grade 2 to grade 4 complication. So it suggests that the and the post-operative death number at 1 month, day 30 of the surgery, there was only one mortality in HMI group and two mortality in OE group. So as we can see, the patient who were alive after this HMI and open esophageal at 30 months, 42 months, the graph has separated, but it was not statistically significant. So the number of patients were alive after both the surgery, and the hazard ratio of that was 0.67. So conclusion of Miro trial, the hybrid minimally invasive esophagotomy versus open esophagotomy, 77% had the lower risk of intraoperative and post-operative major complication and 50% lower risk of major pulmonary complication. But there was a similar DFS and OS at 3 years. So this was the surgery. So right now in TMH, they are preferring TT more than THE. And THE they are preferring in the patient who had the major pulmonary comorbidities, whom there are more chances of pulmonary compromise after surgery. So this was the basic their surgery. But in this, there are multiple lymph node stations which are involving, like we have said, the two-field lymphadenectomy, three-field lymphadenectomy. So what is the two-field lymph nodes and three-field lymph nodes? So two-field lymph nodes they include the upper abdominal till the celiac trifurcation. So it is like the abdominal and mediastinal lymph nodes, standard mediastinal. In three-field lymphadenectomy, they have included the upper abdominal, mediastinal, which is complete mediastinal, as well as the cervical lymph node. So when the earlier surgical pathological specimen was evolving, their T2, T3 tumors with 0 to 4 lymph node involved nodes, the survival rate was significantly better if we remove the 18 lymph nodes. So if the patient has an adequate lymphadenectomy, the depth of invasion was no longer a significant prognostic factor. So how many lymph nodes to be removed, which lymph node dissection to be done, it is evolving in surgical field. So only a lymph node optimal lymphadenectomy has improved the DFS of the patient who underwent only esophagotomy surgery. So how many numbers of how many lymph nodes to be removed that predicts the survival in esophageal cancer? So they have included around 2,000 patients at the 9 international centers. So they only get the surgery without any neoadjuvant treatment. So only predicted for improved survival was the optimal lymphadenectomy. So more than 23 years. So whether there is a lymph node involved or not, it can predict the systemic disease also. So if there is no nodal involvement, though still there will be systemic disease in 16%. If more than 3 nodes are involved, 50% chance have to have systemic disease. If the more than 8 nodes are involved, 93% will have systemic disease. So there was a worldwide esophageal cancer collaboration guideline for lymphadenectomy, which predict the survival following the neoadjuvant therapy. So, if the patient has undergone the adequate lymphadenectomy, so there will be a OS benefit, survival benefit was seen in this patient in across all the squamous cell as well as adenocarcinoma groups. So, in this. So 3-field or 2-field, which dissection to be preferred in thoracic esophageal cancer? There was a one meta-analysis which the conclusion was that the 3-field is a 3-field lymphadenectomy would be a priority for thoracic esophageal cancer, especially who has a positive lymph node. But the sample size were low and it was not very randomized control studies which were included. So further evaluation is needed in these patients. So there were 400 patients which were included in this study. So there was no significant difference between the perioperative complication who has the patient who had under 2-field lymphadenectomy or 3-field lymphadenectomy, and there was no survival benefit at the 48 or 60 months. So to summarize, so we prefer TT because most of the patients we have here has a bulky disease or any nodal positive something disease. The PHA is mostly reserved for the patient who has a high risk of perioperative pulmonary complication, who has a borderline lung function. Lymph node status is the strongest prognostic factor. At present in TMH, they are doing 2-field lymphadenectomy. 3-field lymphadenectomy is mostly done in Japan. And in patients who are undergoing esophagectomy without induction tumor radiation, at least 15 lymph nodes should be removed and assessed to achieve the adequate nodal staging. If the patient has received the preoperative chemoradiation, the number of the lymph nodes is not completely known how much to be removed. Yeah. Thank you.
I quickly summarize this. So there is when they operate for esophageal tumors, there is a particular template that they follow for lymph node dissection. If any of these lymph nodes go beyond the template, and the template is from the supraclavicular node to the celiac trifurcation, any node they do it beyond that. So sometimes they can address the lower cervical nodes in that template, but anything that is higher cervical level 3, 4, 2, they do not address. Any node that is retroperitoneal node below the renal hilum is considered as a non-regional node and is to be considered as metastatic and treated with a palliative intent. So anything that falls within the template can be addressed. Regarding PT and PHE, what is very important is that in a transhiatal, there will be no incision in over the thoracic cavity. So there can be a cervical, there can be a laparotomy that is done. So here the hiatus is the diaphragmatic hiatus. Okay. So there will be no nick over the thoracic cavity. There can be a nick in the cervical region or there can be a laparotomy. When there is a transhiatal approach, generally the esophagus is pulled up so that the anastomosis is there in the cervical region. So if there is any leak, it can be managed easily. What is one problem with the thoracic is that many of the patients over here, they have these tuberculosis, smoking, COPD, emphysema, so their lung results are very poor. That is one. The post-op stay and the morbidity increases. Thirdly, the time for surgery when they do a thoracic approach will be higher, and the chances of the anastomotic leak is higher because the anastomosis is in the thoracic cavity. Whereas if it's transhiatal, it's there in the cervical region. Okay. Then, yeah, two-field and three-field. So, any node positive disease should be addressed with systemic therapy. Okay. So, for the esophagectomy, it has to be a node negative disease. Preferably, you see, we are not dividing that SM1, SM2, SM3, that is something that we don't follow over here. But T1, that is both A and B, N0, can be addressed with surgery. Okay. Any residual disease. So, lymph node positivity after esophagectomy is not good because we need to give that patient adjuvant therapy. We try to give it peri-op so that we assess both the biology of the disease, whether there is a PCR or no, both in the primary and in the lymph node. And accordingly, we can decide what to give in adjuvant. It's like a perioperative chemotherapy or a neoadjuvant chemoradiotherapy followed by adjuvant nivolumab, that is immunotherapy. So our approaches are basically going more into perioperative and neoadjuvant so that we know whether there is a pathological response or no. We know the biology of the disease and what to do in the adjuvant setting. So now all patients are not going to be resectable. In fact, majority of the patients are not going to be resectable. So then the next modality of treatment is radical chemoradiation. So how did radical chemoradiation evolve will be discussed by Dr. Minit.
Good morning. So I'll discuss the role of definitive CTRT in carcinoma esophagus. So if you see the earlier trials of only radiotherapy without chemotherapy as a mode of non-surgical treatment in unresectable esophagus, the overall survival with only RT is not good. The 5-year survival is only 10 to 15% with definitive radiotherapy. So in this context, this comes whether adding chemotherapy with RT will increase the survival and local regional control. The seminal paper has come on 1992 in AEGM, which compared combined chemotherapy with chemotherapy radiotherapy versus radiotherapy. It's a phase 3 randomized prospective study. All the histologically proven adeno and squamous cell carcinoma have included, where the disease of thoracic esophagus, they excluded the gastric involvement. Non-metastatic disease with adequate marrow and renal function have been included. The trial schema showed that in CTRT arm, the total dose of radiation was given 50 gray over 25 fraction with concurrent chemotherapy on week 1, week 5, week 8, and week 11. The chemotherapy regimen being cisplatin 75 mg per meter square day 1 and 5-FU 1 gram per meter square day 1 to day 4 on every week 1, week 5, week 8, and week 11. On the radical RT only arm, they used a higher dose of radiation of 64 gray of over 32 fraction. If you see the randomized all the groups, the age remains less than 70 years. Squamous cell carcinoma remains the predominant histology, and most of the patients are of middle thoracic esophagus. The median follow-up was 17.9 months, with a median survival of 12.5 versus 8.9 months, which favors CPRT arm. And survival rates at 24 months was 38% versus 10%, favoring CPRT arm. If you see the local and distal metastasis, both are higher with radiation arm, and which adds the advantage of combining chemotherapy with radiotherapy. So obviously the benefit of survival and local regional control comes with the cost of toxicity. If you see the combined modality therapy, there is higher chance of gastrointestinal and hematological toxicity, and overall grade 3, grade 4 side effects are higher on the combined modality arm. So RTOG 8501 concluded that it established the chemoradiation as the conventional non-surgical treatment for esophageal cancer with substantially higher toxicity. In 1999, the 5-year follow-up of RTOG 8501 has come on JAMA Oncology. So in this trial, the trial I have earlier explained, they have put the follow-up of at least 5 years in this updated analysis. And also they have performed a prospective cohort study which conducted between 1990 and 1991, which is a single arm only concurrent chemoradiotherapy. So they have analyzed both both these studies in the same paper. In the randomized part of the trial, at 5 years of follow-up, the overall survival CPRT was 26% compared to 0% following RT. And in the non-randomized part, the combined therapy produced a 5-year overall survival of 14%. But if you see the pattern of failure, persistence of disease was the greatest cause of treatment failure in every group, although the failure rate is higher in the radiation arm. So this persistence of disease as a pattern of failure in both the arm has obvious the need of surgery in this group, which might benefit more in terms of local regional control. So the RTOG 8501 final analysis concluded that CPRT improved survival compared to RT alone in T1, T3, N0, N1, M0 adeno and squamous histology esophageal cancer. Since local regional persistence of disease accounted for the majority of treatment failure in this trial, surgery might be able to eradicate some of this tumor. Now coming to role of changing the chemotherapy backbone in the radical CPRT treatment. So this ASCO abstract was came in 2010, where patients with locally resectable carcinoma of the esophagus received concurrent chemoradiotherapy consisting of RT of 50.4 gray over 28 fraction, including chemotherapy, paclitaxel and carboplatin on a weekly basis. The dose remains paclitaxel 50 mg per meter square and carboplatin AUC2. Total 52 patients, median age was 63. The 1, 2 and 3 year survival were subsequently 64%, 32% and 16%. Median DFS was 9 months and median time to local progression was 14 months. The major toxicity includes neutropenia, thrombocytopenia, esophagitis and fatigue. So they concluded radiotherapy with concurrent weekly paclitaxel and carboplatin as definitive treatment for irresectable esophageal cancer is a tolerable regimen which can be given on an outpatient basis and leads to a durable local regional control. If you see the ESMO guidelines, the definitive chemoradiotherapy is recommended for patients with squamous cell carcinoma or adenocarcinoma of the cervical esophagus and thoracic esophagus that is unresectable and locally advanced, or those who are unable or unwilling to undergo surgery. Particularly for squamous cell carcinoma, definitive chemoradiotherapy followed by close observation and salvage surgery on progression remains a fair option in squamous cell carcinoma. Finally, to summarize, definitive chemoradiotherapy should be considered for patients with esophageal squamous cell carcinoma or adenocarcinoma who are unable or unwilling to undergo surgery. Definitive chemoradiotherapy with close surveillance and salvage surgery remains a recommended option for resectable esophageal cancer. Radiation dose remains 50.4 gray. Concurrent chemotherapy backbone can be cisplatin 5-FU or paclitaxel carboplatin based regimen. And local failure remains the major challenge of radical CPRT, which obviates the need of tri-modality treatment and including surgery that could improve the local regional control.
So for those who have attended our thoracic OPDs, this is the backbone for our CPRT esophagus trial. So one arm is cisplatin and 5-FU, so that is the RTOG 8501, which has been the backbone for many years. And the other backbone is paclitaxel carboplatin that has come since. So the paclitaxel backbone is evolving since the year 2006. So Chemotherapy definitely adds survival. So there is an OS benefit. We can see at 5 years at the long-term follow-up, even the median OS survival is there with adding chemotherapy. But which of the two is safer? Also, by giving chemotherapy, do I compromise on the dose of radiation? So that is one of the questions with cisplatin and CISU. If the patient develops grade 3, grade 4 mucositis, diarrhea, is unable to tolerate the subsequent treatment, whether it's either chemotherapy or radiation. So is it acceptable to have such high toxicity and unable to deliver the full dose of subsequent chemotherapy and radiation? So Dr. Navini is actually leading the CTRT trial at our center. Ma'am can throw some lights into CTRT.
Well, same what Minit said, so 5FS is same as the RBOG 501, 75 milligrams of cisplatin and 1000 milligrams of 5FA for 4 days, and our comparators, paclitaxel, the same regimen. So the patients are randomized. Only thing is we use actually our radiation people use a higher dose of RT, they use 60 gray, not what is recommended in most of the esophageal cancer studies of 50.4.
Then we come to the last part of our section, and these are the landmark trials which we are aware of. So we dealt with the evolution of treatment. The last part is about the NACTRT cross trial, the SLOT trial, and we talk about the NeoRes trial, which actually compared the NACTRT and the SLOT trial. And the last is the adjuvant nivolumab. And I think we'll sum it up with that. Dr. Shiva is not well, so Dr. Arvind will take it on behalf of.
So all this we know. We know that NACT improves survival in esophageal cancer, and the comparisons have shown that NACTRT has some survival benefit over NACT. So again, we know that the 5-year OS in locally advanced esophagus is less than 25%, with mostly regional and distant failure. There are multiple trials that have compared chemotherapy to upfront surgery. We'll see. So why do we want to give neoadjuvant radiation? Because we want to decrease the tumor size, decrease the number of viable cells. However, the disadvantages will not be addressing the micrometastatic disease. So there were some trials of neoadjuvant radiation followed by surgery versus surgery alone. All 5 of these trials did not show any survival benefit of neoadjuvant radiation. Following which we had a meta-analysis of 5 trials, including 1147 patients, in which they showed that compared to surgery alone, the neoadjuvant radiation increased the 2-year survival from 30 to 34% and increased the 5-year survival from 15 to 18%. It was not statistically significant. Why do we want to give neoadjuvant chemotherapy? To downstage the disease, early treatment of micrometastasis, and we can assess the response based on the PCR window. But the disadvantage is the local and definitive therapy is getting delayed with the risk of disease progression. Again, there were trials of NACT. The first 5 trials again did not show any survival benefit of NACT followed by surgery versus surgery alone. The only trial that showed benefit was the MRC trial in 2002. So it had 802 patients in which we randomized into group CS and group S. Group CS was 2 cycles of chemotherapy followed by surgery, and the group S was surgery alone. So in terms of PCR rates, it was again superior in the CS group, and this was the trial which showed that overall survivors were also better in the CS group, 16.8 versus 13.3 months, which was statistically significant. So the interpretation was 2 cycles of NACT, which is cisplatin 5FU, improves the survival in patients of resectable esophageal cancer. And then coming to the NACT meta-analysis of 11 studies, there is a 36% response to chemotherapy and a 3% PCR rate. There was a magic trial of perioperative chemotherapy versus surgery alone in resectable esophageal cancer. So this trial studied adenocarcinoma of stomach as well as lower esophagus in GE junction, which was locally advanced. And there were 2 groups. One group they did only surgery, and the other group they gave 3 cycles of ECF, then surgery, followed by 3 more cycles of ECF. What is important to know, predominantly this trial included stomach cancer, and there was only 15% of lower esophagus and 11% of GE junction. The results showed that there was a significant improvement in survival with perioperative chemotherapy. There was improvement in overall survival with a 5-year OS of 36 versus 23%, better progression-free survival with similar rates of post-operative complications, and the resected tumors were smaller and less advanced. So it concluded that the perioperative therapy should be considered in esophageal adenocarcinoma and GE junction adenocarcinoma. There was again a meta-analysis of neoadjuvant chemoradiation. The first one showed that there is an improvement in 3-year survival. The Fiorscia meta-analysis again showed there is a reduction in 3-year survival. Greer et al. Small improvement in overall survival, and Malthaner et al. Again, no difference in mortality at 3 years. So to summarize, up to this point in the treatment of CA esophagus, we had only two options, either surgery alone or definitive CTRT alone, before we studied the perioperative therapies. The first trial which changed the practice was the cross trial by Van Haget et al., which came in 2012. So in this trial, it included esophagus or GEJ tumors, which were both squamous adenocarcinoma and also large cell undifferentiated. So this trial is significant because it included both squamous and adenocarcinoma. The one group received only surgery, and the other intervention group received EBRT followed with chemo, NACTRT followed by surgery. The primary endpoint was overall survival. 75% patients were adenocarcinoma and 25% was squamous cell carcinoma. Again, we see around 178 and 188 patients in either arm. What was the dose used in the trial? It is carboplatin AUC 2, paclitaxel 50 mg per meter square, weekly regimen for 5 weeks, and the radiation dose was 41.4 gray in 23 fractions. This is the same dose that we are also using at our center. What was the result? A significant improvement in survival. So we see that the median OS increased from 24 months to 49 months, more than double. The 5-year OS increased from 34% to 47%. Significantly improved the R0 resection rates. However, there is more grade 3, grade 4 adverse effects, but it is well tolerated. The trial concluded that preoperative CTRT improved survival in patients with curable esophageal and GEJ cancer, both squamous and adenocarcinoma. We see that in the CTRT improved survival significantly compared to surgery, the upper graph. The lower graph is showing in terms of histology. So here we see that more benefit is for squamous cell carcinoma and lesser benefit for adenocarcinoma. For adenocarcinoma, the p-value for benefit was actually just statistically significant. So the brief summary was 94 versus 91% patient underwent surgery. R0 resection rates were much higher in the CTRT group, 92 versus 69%. PCR rates were much higher in the CTRT group, 23 increased to 49%. And as I said, overall survival more than doubled from 24 to 49 months. All the subgroup of patients we see are benefiting. And this is the survival, even at 10 years, the survival is increasing from 25% to 38%. So once we have the preoperative chemo radiation, and we also have the MAGIC trial. MAGIC compared perioperative therapy. So since they wanted to improve on the ECF regimen, they compared perioperative therapy with ECF versus FLOT. Both groups received pre and post-surgery chemotherapy, but the regimen was ECF versus FLOT. Again, this trial only included adenocarcinoma of the lower esophagus and GEJ. It was not for squamous. And what we found is the results is there is a significant improvement in overall survival with FLOT compared to ECF. All the groups of patients are benefiting. Overall survival was again doubled in the FLOT group. It was increased from 35 months to 50 months. With a disease-free survival increased from 18 months to 30 months. And we are seeing the 5-year OS in the ECF was 36%. It increased to FLOT in 45%. Main toxicity, we know that there is more grade 3 toxicities in the ECF group, that was nausea, vomiting. But the other complications like infection, neutropenia, diarrhea, and neuropathy were higher in the FLOT group. Post-operative complications and hospital stay were similar in two groups. So after this trial, in terms of for adenocarcinoma of esophagus and GEJ, FLOT regimen has become the standard for perioperative therapy. Once we have the cross and the FLOT, then we wanted to compare among the two which is better. Is the NACTRT better or is the perioperative therapy better? So the nearest trial, again, we said the optimal modality for locally advanced CSO, we don't know. Both the cross regimen and the perioperative have shown good responses. So in this trial, we allocated the patients. The first group received NACT and the other group received NACTRT. 181 patients in Sweden, again randomized esophageal squamous cell or adeno. Again, the trial included both types, NACT followed by surgery or NACTRT followed by surgery. The dose of radiation was 40 days. However, this trial did not show any survival benefit. As we can see, the survival for the NACT and the NACTRT was same as shown on the left. The graph on the right is showing that Those patients who had more tumor regression and better pathological response, they had a better survival, whether that response came with NACT or whether that came with NACTRT. So CTRT significantly increases the proportion of patients with complete histological response. So CTRT increased the histological response rate, the PCR rate, and the R0 resection rate. However, this did not translate into an improvement in overall survival. So the 3-year overall survival was 47% in the NACT arm and 47% in the NACTRT arm, not significant. However, the patients who received the neoadjuvant chemoradiation, they had a much higher incidence of post-surgical and perioperative complications, which led to more perioperative mortality in the first year of follow-up. This is showing that those who had NACTRT, they had a higher incidence of perioperative complication. The blue part of the graph is much higher in the NACTRT group. So the takeaway from this trial is that although the addition of NACTRT increases the histological response and the R0 resection rate, it does not increase the overall survival. And the last trial is the adjuvant nivolumab in resected gastroesophageal and stomach cancer. So there were two trials, the attraction 2 and 3, in which they showed that among patients with resected esophageal cancer, those who received adjuvant nivolumab had a longer survival. So this was the Checkmate 577 trial, which they included both adeno and squamous cell carcinoma, post neoadjuvant chemoradiation and surgery. Those patients who had a residual disease were randomized to either adjuvant nivolumab or adjuvant placebo. The nivolumab and placebo were given for 16 weeks. So this trial included patients with residual pathological disease, and we know that those who have residual disease after surgery are at a higher risk of relapse and death compared to those who have a complete pathological response. And more than half of patients had lymph node positive disease. In this trial, there was a significant improvement in disease-free survival, which was 22 months in the nivolumab group and 11 months in the placebo group, which was significant. And despite the poor prognostic factor of residual disease in these patients, nivolumab was associated with a significant improvement in disease-free survival and a 31% reduction in the risk of recurrence and death. And there was a sustained separation of the Kaplan-Meier curves, which showed that the benefit of nivolumab was sustained over a longer period of time. And this graph again is showing that all the subsets of patients did better with nivolumab compared to placebo. This is showing that the patients who received nivolumab, there was less distant recurrence. There was also less local recurrence, showing that it had a benefit in both preventing the distant recurrence as well as the local recurrence. When we divided the patients as per the PD-L1 expression, it showed that nivolumab was effective irrespective of PD-L1 status, whether it was less than 1% or more than 1%. So all patients had a benefit with nivolumab. And among the patients who received nivolumab, the benefit was higher among those who received early, those who received less than 10 weeks after surgery, compared to lesser benefits among those who received more than 10 weeks after surgery. So the takeaway from this trial is in patients with resected esophageal cancer, both squamous and adeno, post neoadjuvant chemotherapy, if there is a residual disease, giving adjuvant nivolumab significantly improves the disease-free survival with a very tolerable safety profile. The brief summary of the treatment, as we say, in squamous and adeno, in squamous cell carcinoma, we can go for neoadjuvant chemotherapy followed by surgery or definitive CTRT. And in adenocarcinoma, both the options are acceptable, either the FLOT protocol, perioperative FLOT, or the cross protocol, neoadjuvant chemoradiation followed by surgery. Post-surgery, if there is residual pathological disease, we will recommend adjuvant nivolumab for both squamous cell carcinoma as well as adenocarcinoma. Thank you.
I just briefly in this 2 minutes summarize perioperative therapies because it is important and it's important in our routine clinic and it's important in the JC. So the cross trial has definitely revolutionized the treatment or changed the standard of treatment of how we manage esophageal cancer. But the most important is the inclusion criteria. The disease should be 5 centimeters away from the trachopharynx, not more than 8 centimeters in length, not more than 5 centimeters in width. Okay. So, and they should be either node positive, that is any T but node positive, or T2 or higher. Okay. So once they satisfy the inclusion criteria, patients can get neoadjuvant chemoradiation. So it's NACTRT followed by surgery. The perioperative part is that NACTRT followed by surgery. If there is any residual, will be followed by post-surgery nivolumab for a year. So that completes the perioperative part of it. Those who are receiving only chemotherapy, the standard is flawed. So we are not coming to the trials right now which are adding immunotherapy to perioperative. They are still, the preliminary results have come. We don't have long-term data, but as of now, if we are following a perioperative chemo approach, it will be flawed or ECF. We are no longer using ECF or ECF. It will be flawed perioperative followed by observation. Okay. We are not changing, that is escalating or de-escalating treatment based on the PCR that we get post the neoadjuvant slot. Okay. So even if there is residual disease, there is PCR, we are giving post-surgery slot to everyone. Okay. The escalation, de-escalation trials are also ongoing. For NACTRT, if a patient has received NACTRT, post-surgery, we have a chance of escalation in the form of nivolumab or de-escalation in the form of observation. Whether it's NACTRT or it's adjuvant nivolumab, the squamous subset had the maximum benefit. So if you look at adjuvant nivolumab, it is 22 months versus 11 months. But if you look at the squamous subset, it is 29 months versus 18 months. So there is a huge 10 months additional benefit in squamous. Similarly, the PCR rates were 29% in the overall group with NACTRT. The PCR was 49% with squamous cell. So there is one particular subset which is benefiting more, and the Western trials were unable to represent that because only 20 to 25% was squamous. But our patients, majority of our population, 70 to 80% is squamous. So we know that these treatment modalities or strategies are going to benefit our patients also. So these are the common trials that we use in our day-to-day clinic and in our JC.
Nothing, I agree whatever Minit said, except that the cross, just to note that it was a very select group of very fit patients, PS 0 to 1, less than 75 years of age, tumors which had to be 3 centimeters below the glycopharynx, not more than 5 centimeters in width, not more than 8 centimeters in length, and then T1N1 or T2, T3, N0N1. All these are usually not the kind of patients that come to us. So we were not initially using the cross protocol so much. Most of the time we don't meet that even volume criteria, but of course now a lot of CPRT in the neoadjuvant setting has been started. But that is one thing that you need to remember. And after the CPRT, then again surgery and then followed by adjuvant is where we don't get such fit patients, and often completion of therapy is a problem that which we need to monitor and optimize the patients to deliver both this peri-op, whether it's NACRT followed by surgery followed by nivolumab or peri-op chemo. So again, optimizing the patient period post-op is also important.
Question, I think it's 9:30.
Why is adding nivolumab later rather than earlier had nivolumab? And the second question is that with the surgery, one of the complications mentioned was clearly reflux. We are not even touching the pilot, which is why it will be attacked.
So basically when you operate, we probably should discuss with the surgeons, but I think not mechanically touching the pylorus, but the stomach is pulled up to anastomose if it's a esophageal. So there would be some amount of like how you have a paralytic EVS type of a thing when you are handling the bowel. So definitely there will be some probably dysfunction there, and that is why you would get the biliary reflux. It may not be that you're touching the pylorus, but you're handling the stomach, especially if you have a G-junction tumor, which would have a impact on that. And maybe there are going to be a gastric pull-up with an anastomosis and so much of handling of tissue. But definitely there will be some involvement there. So the bowel, the upper, at least the stomach will get affected. It won't function, and peristalsis may not be normal. So you would expect biliary reflux. So we probably need more data on that, why that happens. Now that early versus late and late versus early benefit there are variabilities in across tumors. So in lung, it is early that is benefiting more. So they saw within 15 days in Pacific, if you give nivolumab, they had much better benefit than if you give after 15, though the trial allowed till 42 days, that is 6 weeks. But why later benefited, we don't really know. Probably those patients need to be like dissected out and looked at what are the factors that would impact the response of immunotherapy more in that patient. Because one trial and limited data is difficult to really say why. But they could be, these intervals of starting maintenance or adjuvant immunotherapy are known. In lung, we have seen it. But in esophagus, the results have been contradictory. Why it is so, it's not clear. But now there is a lot of teleop immunotherapy data which is going to be there. Like it's going to be like lung, where you give chemo, neoadjuvant followed by surgery, followed by adjuvant maintenance for a year. Like how they're having in lung. So a lot of the trials are ongoing. So these questions will probably be answered better when all those results come.
Yeah, and one part of the adjuvant nivolumab I hadn't touched about is the question that they asked here. So can the data be extrapolated? So all the trial that they use is NACT, RT, surgery, and post surgery adjuvant IO. But what about those who cannot receive NACT, RT, and have only received NACT and still have a PCR? So the data is extrapolated from the checkmate 577 using the adjuvant setting. No clear-cut randomized trial data for adjuvant nivolumab post NACT, but if somebody has significant residual disease, that is mostly in the form of YTNs, that is the node pulsar disease, adjuvant nivolumab can be used in such a scenario. So this is one of the situations that we commonly face in our OPDs, that NACT is given and can we give adjuvant nivolumab? No clear-cut data, but yes, the data can be extrapolated from checklist analysis.
The data will come because there are studies which are looking at chemo plus immunotherapy followed by surgery followed by maintenance immunotherapy. So probably once these studies get completed, we will have that data that if you don't give NACT, RT, and you give only chemo and operate, then what happens to the patients if you add immunotherapy?
There are no other questions. I think we can close. Thank you.